Drugs causing gastroesophageal reflux disease, that is GERD. Following are the medicines which cause GERD by irritating esophagus. It includes antibiotics, that is clindamycin, tetracycline, and doxycycline, bisphosphonates, for example, aniline dronate, iron supplements, quinidines like HCQS, NSAIDs, which are very commonly used as painkillers, and potassium supplements. Following medicines cause GERD by decreasing the lower esophageal sphincter pressure. The medicines which can cause are anticholinergics. Among antihypertensives, they are calcium channel blocker, ACE inhibitors, and nitrates. Among oral hypoglycemic agents, they are liraglutide, metformin, and glyburide. And then statins, narcotics, progesterone, sedatives, for example, benzodiazepines, tricyclic antidepressants like amitriptyline and theophylline. So we have seen that medicines can cause GERD by two mechanisms, either by irritating the esophagus or by relaxing the lower esophageal sphincter. Now we will read about some medicines in detail. So first we'll go through the medicines which irritate esophagus. So tetracycline is very acidic and directly irritates the esophagus. Clindamycin also causes irritation and erosions of the esophagus. NSAIDs disrupt prostaglandins. Prostaglandins are increased in inflamed tissue and cause cardinal signs of acute inflammation like pain and swelling. So we use NSAIDs as a painkiller. Now, prostaglandins are found in high concentration in the gastric mucosa and gastric juice, and they inhibit acid secretion and stimulate mucus and bicarbonate secretion. If we use NSAIDs, they disrupt the prostaglandins, causing decreased formation of mucus and bicarbonate and increased acid secretion, which causes GERD. So next is bisphosphonate, which is very commonly used in elderly people with osteoporosis. The comparable molecular structure of bisphosphonates and phosphatidylcholine create competitive binding on the gastrointestinal lining. Now, what is this phosphatidylcholine? So, the surface mucous cells synthesize and secrete surfactant-like phospholipids, notably phosphatidylcholine, which are recruited to the luminal interface of mucous gel layer. So, in the stomach, where the mucus layer and the acid layer come together, meet together, there they are synthesized and secreted. Now, they render the unique hydrophobic properties to mammalian gastric tissue, making the tissue non-wettable to the luminal acid. Now, when bisphosphonates bind, the hydrophobic barrier is destroyed and gastric acid is able to reach the epithelium lining, resulting in irritation. Iron supplements like ferrous sulfate become very acidic when it dissolves in saliva. So, this means it can injure the lining of the esophagus or stomach as it dissolves. Quinidine and for potassium supplement, the reason is not known, but the natural potassium supplementation, I mean from diet, does not cause gastric irritation or esophageal irritation. So now we'll go through medicines which decrease ileus pressure. So anticholinergic agents, for example, dicyclomine, which is given in abdominal cramps, calcium channel blockers, and opioid agonists, all display antispasmodic activity by reducing the excessive contractility of smooth muscle cells, which are found in the GI tract. So they relax esophageal muscles also, causing the GRD. Now this effect is used as a benefit also, like calcium channel blockers, like nifedipine is used in achalasia and diltiazem is used in patients with chest pain secondary to excessive esophageal contraction. Whenever we use ACE inhibitors, then the substance P and bradykinin are increased in amount in our blood as they are destroyed by the ACE. So neurogenic inflammation is mediated by release of tachykinins, that is substance P and bradykinin, from sensory nerves. GLP-1 receptor agonists like liraglutide, they delay the gastric emptying, increasing the chance of gastroesophageal reflux. Metformin increases GLP-1 concentrations and the bile acid pool within the intestine and alters the microbiome. Statins. For statins, there are conflicting results ranging from a significantly higher risk of GRD among statin users to a significantly higher risk of GERD among non-users. So the reason are two. First is nitric oxide plays an important role in the regulation of the lower esophageal sphincter tone. Its increased level relaxes LES. A study in rat has demonstrated that statins can decrease nitric oxide production. Second thing is oxidative stress and inflammatory cytokines are important players in the pathogenesis of GERD. Therefore, use of statins could possibly decrease the risk of GERD through their antioxidative and anti-inflammatory effect. Here are some of the references. Thank you.